breast condition, mammary duct ectasia, intraductal papilloma, and breast cancer. I have pictures for breast cancer, so beware. With fibrocystic breast condition, this usually happens in women between the ages of 20 and 50. It causes basically these multiple cysts, and they're not always fluid filled, and they're not always, they just make the breast feel lumpy. And so it's not as nice and firm and smooth as other people. They sometimes relate it to excessive sodium, excessive caffeine.
Caffeine makes them hurt.
It's often found in larger breasted women. Because I promise you, I've already heard this, and I've been told to cut my caffeine intake, so I'm down to 1 cup of coffee. So if I ever see cranky y'all in the afternoon, you just can't have that second cup. Signs and symptoms. Most people will just say their breasts are lumpy. They may be a little more tender. They'll notice it more during menstruation or right before menstruation. Objective, they're usually it just feels a little more nodule than normal. Diagnostic tests, they may ultrasound. Most of the time they'll do the clinical breast exam by your clinician, and then they'll determine if ultrasound is actually necessary. Treatment's mainly conservative. They do use fine needle aspiration or biopsy sometimes just to rule out cancer. But that's if they really suspect or if there's a really large nodule. But this is where, when we teach our patients self-breast exams, the idea behind self-breast exams, and I have it several places, is that with a self-breast exam, we want the person to know what their own breast feels like. Because if you do a breast exam on you and then you check someone else out, you're like, what is all this? So you've got to learn to know what's normal for you. Because like me, I have fibrocystic breast disease, so I'm pretty lumpy. I just know what lumps are normal. So if one lump starts feeling larger than the other, I'm like, we might need to get that checked out by the doctor. Okay? If you notice something different, because they're still not going to have these great big borders with the fibrocystic breast disease, so you're not going to notice. So you look for any abnormalities. And once you find them, you seek medical evaluation. Your management is diet modification, leaving off the caffeine, exercise, weight loss. And y'all, I'm trying to do it without my notes today. So if I go back and I give y'all a little extra information, it's because I forgot to say it. And this is the American Cancer Society recommendations about monthly self-breast exam. They changed it for the longest time. It was after the shower, up in the mirror, starting right up around 400, start checking around. It was moving circular motion. They still allow the circular motion, but now they recommend the week after the period, you do this, but you lay down flat. And move in a circular motion. But what you do is you don't lift your fingers up and try to go around. You move in a circular motion all the way around the body. There is a YouTube video you can watch. I think the link might be active on the copy that y'all have. If not, y'all can just cut and paste and put that up to watch it. It's a self-breast exam, so obviously graphic photos. Alright, ductal ectasia. This one is a benign condition. Most women find it as a mass in their breast, and they start having this odd nipple discharge. It's usually green, milky. Yeah, this is infectious in nature. Can y'all tell? It's usually a painful, tender mass. They press on it, they start having. What it is those mammary ducts have gotten some sort of infection in them. And usually, since they're painful and they're tender, and they have that greenish nipple discharge, they may have a little bit of blood in it from the infection. The other symptoms, they're all going to be similar to that of an infection. Redness, warmth, tenderness. Treatment, what do y'all think the best treatment for this is?
Antibiotics.
Sometimes. Sometimes, if you keep it clear and help it drain, goes away on its own.
So keep pressing on it.
Other times, if that's not working, they may have to go in there and surgically IND that. I know, it already sounds awful, doesn't it? Surgical INDs, you use heat to reduce the swelling, warm compresses to the area. They sometimes, antibiotics are a medication of choice at this point. And then the surgery is going to be mainly your IND, or they'll have to remove, if it's bad enough, they may have to actually remove the duct that's infected. I'm going to take a second to look at my notes to make sure I didn't miss anything. Oh yeah, on fibrocystic breast disease, they'll use hormones to help too, such as oral contraceptives and something called selective estrogen modulators, or estrogen receptor modulators. We talked about SERMs with the BPH though. So if y'all had me last semester, those were snuck in there.
They use the hormones for what?
For the fibrocystic breast disease.
Can you say the hormone thing again? You said hormone receptor or hormone selective?
A selective estrogen.
Selective extra.
It's hot. Yeah, it is hot in there. And I'm usually cold. But it may just be because I'm talking. Selective estrogen receptor modulators. Okay. The intraductal papilloma, which is next. These occur in women between the ages of 40, 50 years old. Now, it's been benign and it's really poorly defined, and because of this, sometimes it's harder to detect this. But it's not really cancerous at this point. Although having something like this can lead to cancer. And a lot of times with this, the treatment is just ruling out breast cancer to make sure that it's not cancerous. They can go in there and cut it out when they find it. You want to give them the self-breast exams, educating them on that. Screening, they may have some pain with this one. So you're going to look at pain relief, and if there's anything that they're really concerned about, they're going to refer them out to someone else. You also want to refer them to support groups. Does anybody know what gynecomastia is?
Breast in men.
Yes, breast tissue in men. It is usually benign. It can be steroid induced. It can actually be, for level 2, my talking BPH, there's SERMs and stuff that they were taking to help decrease testosterone. It can be a side effect of those medications. It is usually a symptom and not an actual disease process. Only about, I want to say 1 to 2% of men have this. As they get older, men don't produce as much testosterone. If they have underlying cancers like prostate cancer or something else, they can start experiencing gynecomastia. Or a testosterone deficiency. That's why, if you know, have you ever noticed when men age, their voices start getting a little higher, they don't have as much facial hair? This is because they produce more estrogen than testosterone, so they're starting to lose that bass sound or the extra hair that they used to have like on their chest or their face. But they may also develop gynecomastia. Breast cancer. These are where my photos get really, really bad, y'all. Okay? Statistically, if breast cancer is found before it is spread, if it is still what they call a happy little in situ, and we'll discuss that in a minute, there is a 98 to 99% survival rate. The more advanced the cancer, the survival rate goes down. If it's confined to the breast only, the survival rate is about 85%. Once it spreads into the lymph nodes and the surrounding area, it goes down from there. Cure. What's the cure for breast cancer? There isn't. Our solution is prevention. Remember, an ounce of prevention is worth a pound of cure. This is why. Or recognizing the symptoms early, because you want to be part of that 98 to 99 percentile where you recognize something's wrong, you get it removed, and you don't have recurrence. Assess their history. What do you think would put these people at risk for developing breast cancer? Correct. If they have a family history of breast cancer, if mama had breast cancer, and y'all, this is a sad story, but I'm gonna tell it anyway. I have a friend, she's fine, by the way. Mama had stage 4 breast cancer when they found it. Mama died of breast cancer. But when they found mama had breast cancer, one of her older sisters decided to get checked. Because she decided this is going to take, if mama has it, there's a chance I have it. You know, when they checked her, they found that she had stage 2 breast cancer. So my friend, obviously being concerned, since older sister had breast cancer, she went in to get checked out, and she had breast cancer. But she had stage 1. Every one of her sisters, and mind you, she is one of 5, has had breast cancer. She has a genetic predisposition that BRC1, BRC2, and I know I'm probably not pronouncing it right. She has a genetic predisposition, and because she knew it was such a high family occurrence, my friend opted for the bilateral mastectomy. She's like, just get them going because we're not risking this again. She has 4 kids. I think the youngest one is about 15 now. She said, I'm not gonna sit and worry about whether I'm gonna make it to his graduation. But some of the other risk factors are if you start your period really early. Because you know, girls these days are getting periods at 9 years old. Some people start as late as 15 or 16 years old. And late menopause. So if you don't go through menopause, or your family, it's anything like my mom's side of the family, they don't go through menopause till their early 60s.
Oh, Lord.
Uh-huh.
I thought the earlier
During my period,
I thought the earlier you started your menstrual cycle, the earlier you went through that.
No, it's not always. It is not always a guarantee that if you start your menstrual cycle early, you will start menopause early.
Okay.
Some people do. It's actually, if you look at your family genetic traits, you will notice a pattern. Because according to my mom, she started her cycle around May, but I don't know about her menopause because she had to have a hysterectomy.
And do you always have that if you have a hysterectomy? Does it always seem to give you the symptoms of menopause?
No, and we'll discuss that in a minute.
Okay.
Okay, people who are overweight, eat fatty diets, although there's no like 100%. If you smoke, you are at risk for cancer. I hate to tell you, if you smoke, you're at risk for every cancer in the world.
Yep.
Lung cancer, Colon cancer. And believe it or not, do you know what the leading cancer in women is?
Lung, isn't it?
Lung. Second most common cancer in women is breast. Lung beats us out because we still, every
Right.
once in a while, are around somebody that doesn't. And I know vaping has become like the fad. And you realize that popcorn lung can lead to lung cancer too. I know this is a little extra information, but you may as well know it. All right, detection. When they're younger, we rely a lot on the self-breast exams and the clinical self-breast exams, clinical breast exams provided by your provider. That's why you go to your gynecologist every year, check out.
They changed it.
They did change it to every 3 years, and I'm not always thrilled about that myself because my GYN still sees me every year. I'm just like, no, I'm coming for the annual. I don't care.
Yeah, it says that 10 years worth of food. Back burner those 3 years, and I was like, so you're putting me on the back burner?
Well, because I know a lot can happen. In fact, I was talking to a nurse practitioner who did OB, and she was doing an annual cap on a lady who hadn't had a cap in 5 years. And do y'all know what a skull can is?
Mm-hmm.
I know if you're old, you know what it is. It's about this big around. She went to palpate that uterus, and she said she felt like she hit a skull can. It was hard. It was that big around. And she had to send them to oncology straight away because she knew that woman had cancer. Early detection is our best chance of survival for these things. Invasive versus non-invasive, if it's non-invasive, you've got a better chance of survival. Invasive means it spreads to the surrounding areas. Metastasis means that it has gone from the site it started to another site. That doesn't always mean that they still have this cancer here. They could have had a mastectomy, but the cancer cells have gotten into their bloodstream and they moved to a different area, and now they have cancer elsewhere, even though the root cause is actually the breast cancer. It is usually found in the upper outer quadrant on this side. This is a very advanced case, but it was a good visual to let y'all see, especially since you can see if you divide it into the quarters here, it looks like it really started in that upper outer quadrant. They're non-tender, they're fixed, got hard irregular borders. You can't always find where it starts and where it finishes.
Is that after a chemo treatment or something?
No.
Maybe before that?
That's not a radiation burn?
No.
Oh, wow.
Why would you let it get that bad?
I've got one that's worse than that.
You might not realize it. Maybe she didn't do self-breast exams. And she thought it was just something maybe. And sometimes when they're that advanced, cancer eats everything. That includes your skin cells. What you see there is cancer.
Breast cancer.
Well, they may have been advanced enough that the doctor
No worse.
said there's nothing more I can do to you, and then it operated out.
I don't know. They took it out.
Does it got any hair in it?
You have no idea.
They took it out.
Now, advanced signs, y'all know, weight loss, poor appetite. They don't. No. This is only for advanced signs. Nipple retraction. Oh, and this is the part. There's something called the shortening of the Cooper's ligament. And when it happens, if women lean forward, they'll notice a dimpling or a puckering in their breasts. So if you want to check that out tonight. Ew, that one's bad. Okay. There's also something called pure d'orange, and I know I pronounced it wrong because it's like French, and I'm not good at that language. But what it means is orange peel skin, where their skin is tight, erythemic, and the actual little, it actually like dots in like your orange peels do.
Take it out.
All right, this is the relative location of malignant lesions of the breast. You see how 50% start right there?
Yeah, that's where that one looked like it started.
Mm-hmm.
Wanted to show you.
Sometimes they do still have lumps. And if you look, you see how everything's interconnected and our nice little lymph nodes. And our lymph nodes are like our little garbage trucks. So they move things out, they get fluid out, they get toxins out. So if we start taking them out, then we start having problems. But the thing is, if we caught some cancer cells in there, you're shipping them everywhere. Additional risk factors: not having any children, not breastfeeding any children. Yeah, I know. A genetic predisposition, pregnancy after the age of 30. I think most people just had a minor heart attack. How many of y'all are going to your OBGYN after we finish?
Not
Protective factors, breastfeeding your children, having a child before the age of 30. Self-breast exam.
No.
Shay's like, no, not happening.
Educate, educate, educate. You're going to teach your patients about self-breast exam, monitoring for things like this. This is one of those things while it's scary.
I said, if I'd have made it to 30 without kids, I'd have never had none.
I don't know. I wanted kids so bad. I told somebody if I made it to 30, I was going to have one without a guy. But I met my husband at 25.
So you just fit underneath there, huh?
Well, I had my daughter at 27 and my son at 31. Yeah, y'all. If y'all don't know, I'm old. I'm under 40, but not by much. That's how we'll go.
Yeah, me too, for about 17 more days.
I joke because y'all realize I've been a nurse for like 15 years. I tell people I started nursing when dinosaurs roamed the earth. Of course, back when I started, now I didn't have to handwrite stuff, but we used Scantrons.
I wish we used Scantrons.
Hey, no, you don't, because y'all realize, y'all know a general idea of your grade when you leave this class, except your final. I had to wait 2 to 4 days to know what I made on that test. Oh, yes.
I still
And
prefer
if you were to tolerate your exam,
I like paper.
Okay, guys, let's get back to this. We also do mammograms. Do y'all remember what age we start mammograms on women?
40. Unless something's noted.
Yeah, if you have that strong family history, like my friend, they'll usually start it at 30. My friend was actually 38.
Or when I had to go get mine because I had an issue, but they asked me if my mother had any kind of cervical cancer or ovary cancer before the age of 27, then that would lead to me possibly getting breast cancer or something.
If you have a family history of any cancer, it increases your risk of every cancer. And that is a simple answer. If you have a family history of any cancer, it increases your risk of
Yeah, because my mom had cervical cancer. 23.
With the mammograms, the reason we don't use it on younger women is because usually the breast tissue is denser, so it's harder to get a good picture, especially since they like iron them flatter than a pancake.
Yes, they
What happens if you don't have?
It still gets smushed like that.
They'll smush what you got. This is just an honest answer. They don't really smush you, and if you're a larger breast woman, it's not exactly comfortable. But I'd rather go for prevention than have breast.
Mine's out.
All right, high risk women, they're going to do the close surveillance. They're going to get clinical breast exams every year. They're going to get the mammograms we were talking about starting around 30. If they find anything or they couldn't get a good view, they'll go ahead and ultrasound, because if they see anything on a mammogram, they'll ultrasound you to see if it's really actually like a fluid-filled sac or if it's actually a big issue. They can do MRI screenings. They do mastectomies. What about these last two? Do y'all know what that last one is? Right? Well, one of the last ones.
Refractomy, that's the removal of the ovaries.
Yeah. The refractomy is the removal of your ovaries.
Salpingectomy is the toes. Salpingectomy is the tubes.
All right. The anti-estrogen chemopreventative drugs. Do you know why they would take out your ovaries if you have breast cancer? Right. Because some of these breast cancers are hormone driven. It's all the estrogen floating around in your system. So if we get rid of that estrogen, we can kill that cancer. The anti-estrogen chemopreventative. Yes.
I was gonna ask, most birth controls have estrogen in them. Does that make you more at risk for breast cancer?
It can increase your risk, but they say it's usually not significant enough to make a difference. As long as you follow up with the annual checkups or every 3 years. Yeah, like I said, I call my clinician every year and I'm like, time to balance. All right, the ductal carcinoma in situ means it is confined to the duct itself. Okay? It's not going outside the area, and those are the best places to find it, because in situ means it hasn't gone into any of the surrounding tissue, period. The lobulars are more like the lobes of the milk-producing glands. And the same thing, this one's in situ, which means it's combined or confined to that area. Infiltrating carcinoma means it has gone beyond the duct itself into the more breast tissue. It made it into other ducts. And fibrosis is what occurs actually to the surrounding tissue before the cancer gets to it. They kind of fibrose and then it takes over. Inflammatory breast cancer. That's when it's gotten into the entire breast. Remember our nice little photo over there? Breast cancer in men do have it. Remember that gynecomastia I talked about? Y'all know gynecomastia doesn't actually have to be bilateral. They can have one breast and not the other. But if you notice that they have one breast and it's feeling kind of lumpy, then you would be more worried about it being some form of breast cancer. Men only make up 1% of breast cancer statistics. Atypical hyperplasia is the abnormal cells. They're non-cancerous, but they can turn into cancer. All right. If you found out tomorrow you had breast cancer, would you be very happy at this point? All right, so when you're dealing with these patients, because you'll have them post-surgery, and the doctor may pop in after they've woken up enough and go, hey, I got something to tell you. I'm massive about cancer. They're not going to be too happy either. They're going to be upset. They're going to be anxious because now they have to go with cancer. That means chemotherapy. What if their mom died of cancer? They're not going to be thrilled at all. And then they're going to have issues about, well, do I choose this treatment option? Do I choose that one? What if it changes how I look? The idea for decreasing the risk of metastasis obviously is removing the cancerous tumor, but we have to look at what will be best for the patient. Our surgical management is going to be, they can do a lumpectomy, they can do a mastectomy. The most commonly chosen one by females at this point is a mastectomy. Just like my friend, take it off. Well, let's not worry about this anymore. They'll do radiation therapy, chemotherapy. They'll also do that the hormone drug therapy, and it's usually for like the hormone reduction. They'll also use their sperms here. Hormone therapy, getting rid of that estrogen. And they do stem cell transplantation. It's mentioned in your book, but there's not a whole lot of information. I just know that they're trying that in patients with breast mass. Breast cancer in women tend to be a much more aggressive form, but less than 5% of young women actually get breast cancer. So you got better odds there. Screening tools, that's what you're looking for. Those monthly self-breast exams, the clinical breast exams when you go to your provider. And we've already talked about the symptoms. The difference, though, is since these are more aggressive, they're going to grow faster. You're going to feel a lump one month, and you're going to be like, let me check it next month, and it's going to be bigger. It's going to be an automatic, oh no. This is another picture, and this is more of the lymphatic spread on breast cancer. See all the lymph nodes you're connected to and how quickly it can go from here to here.
And can travel the whole body, right? If it gets in the blood.
Yes, once cancer gets into your blood cells,
Breast cancer can be breast cancer in your back or in here.
breast cancer in your spine, your
wherever it originates.
your
from.
bone, your tissue. It's just where it originates from. So it can spread anywhere. And that's another reason they do chemotherapy, is to remove all the excess cancer cells. That's why they do chemotherapy and radiation sometimes. It's not to make sure that they got everything up here. That's to make sure that if it got in your lymph nodes, we kill it before it settles down anywhere. Because it's so easy for that lymph node system to pick it up and truck it to a different area. Alright guys, this is the surgical management, and I have several pictures on this. And the reason I do is because of the different types. They can have a total mastectomy, and that's what they call a simple mastectomy too. And I'm like, what's the difference?
How's it simple?
I know, it's not simple. Although some doctors, and I'm going to be honest, they worry so much about taking the breast, they leave the little side boob.
And you're like, why didn't you take that too?
I know. I actually asked the doctor once, and he said that wasn't important. The important part was getting rid of the cancerous tissue. I'm like, still, I wish they'd like to look a little better than having that third boob. One lady joked and said she was going to smoosh it over so she'd just be able to fill her bra up. The modified radical mastectomy is actually one where they go in. Because see, with the total, they still take the breast and they take the lymph nodes, but they'll sneak up there and take a few. And with the modified radical, they'll actually just cut all the way up to there, take out the lymph nodes and all the surrounding tissue, and they may even take out a portion of the muscle behind the breast.
Just to make sure it's all gone.
Just to make sure they've gotten everything. On breast conservation, y'all know the Save the Tatas movement. These are some of the options. If it's like the ductal carcinoma in situ, that they can choose where they go in and make a incision and remove the cancerous tumor and the surrounding tissue, the lump and surrounding tissue removal, and then they'll just tighten it back up. It doesn't happen very often because a lot of people, once you have breast cancer, are like, nah, we're not running this risk anymore. They're gone. Pre-op. The biggest thing is going to be for these patients, what do you think their pre-op issues are going to be?
Coping.
Like pain.
They're going to have, that'll be post-op then.
I mean, like thinking about it, like worrying.
Their biggest thing is going to be anxiety.
Yeah.
They're going to be worried a little bit about the pain, but their biggest thing is going to be anxiety,
Because they're worried about
altered
losing their breath.
body image. Then they're going to be concerned about how other people see them. What if my significant other doesn't want me anymore because he's been a breast man all my life and he's losing a titty to play with? Now, people really do have these stressors because they're worried about how other people will receive them.
Yep.
In my lesson.
Their significant other, their family members, are they less of a person because they lost their person?
And depending on age, another concern is, will they be able to have children after they start chemo?
Correct. Another one of their
That's
concerns,
for any cancer.
very much so. Another one of their concerns is if they start chemotherapy, will they be able to have children? Well, this is a young woman. She's one of those less than 5% that got that aggressive cancer, but she wants babies in her future. There's a good chance this is going to change all of that. A very good chance. Because she has to do like those estrogen inhibitors and stuff, and she's not going to be able to have babies. Although now there are more options, like they can produce eggs and freeze her eggs now, and she can have like a donor who carries her baby for her.
Surrogate.
Surrogate, yes. So there are a lot more options out than there were 20 years ago, which is nice. Remember to make sure, pre-op is usually, and I know you've got to make sure their anxiety is good before you start telling them stuff, but pre-op is usually the best time to educate them about what to expect post-op. Because if they are sitting there and you've got them calm and they're like, okay. Like my friend, she really didn't have a lot of pre-op anxiety because she was like, nope, we're going to get rid of this and we're going to be fine. Because her sister had gone through her stuff and her sister was doing great. She's like, we're going to do this and we caught it really early, we'll be fine. So you have some people, but that was a good time to educate her about what to expect, like the post-op pain, that she may have altered sensation. You still want to watch that to make sure it's not really bad. Or if they lose, so y'all remember the 5 Ps? I talk about it more in, right, and because, not just because they're taking the breath away, but because they're accessing these lymph nodes and nerves up here, there's a chance that they could cause damage to the arm. So you have to look for that, and you have to assess for that in your patient post-op.
Don't they need to do like certain exercises?
They do. Give me a minute. It'll show. But you can also tell them about these exercises before they get started. So they know about the stuff that they'll have to do. Pre-op, they may have like some numbness, tingling. You also want to watch for lymphedema. Because remember I talked about those lymph nodes being dump trucks and carrying off excess fluid, stuff like that. Well, if you don't have those little dump trucks to carry, you get a lot of swelling. It can be worsened by putting tight and restricted clothing. This is the normal anatomy. This is the simple mastectomy. This is the radical modified. Radical modifieds usually have drainage devices, although a simple will too, a lot of times. And this picture I use because while this is bilateral, those are the drainage devices. Has everybody seen a JP drain? Mm-hmm. Okay, y'all know how JP drain works, right? JP drain, it's more of like a gentle suction. What it is you have a little ball. It's usually like oval shaped, looks more like a grenade to be honest with you. And you have to squeeze it and close it. And it's a closed system and it uses that pull of trying to open back up to draw in the drainage from the area so it's not building up in there. Because if they take out the drainage too soon, they have to reinsert it. And occasionally, if people have a lot of trouble, I did have this one lady on compound where the doctor actually had to go in and aspirate the drainage every so often because she wasn't healing up as well as he wanted her to. JP drains, you have to monitor. If this is your patient, you're going to want to empty those so you can see what type of drainage it is. Because what type of drainage would you expect out of these JP drains? Nah, they can have up to 50. Sometimes 100 first time out. But what you're going to expect is it's going to be more serosanguinous. It's going to be real bloody, especially the first few days. It's supposed to decrease over the first week. These patients, when you first get them, expect a good bit. You'll have to empty them pretty often. But you want to look at it and measure it, because what if suddenly, while you're taking care of your patient, instead of just looking, see how that is, it's suddenly bright red? Or maybe it turned a funky, milky, greeny looking. You know, usually we have a problem. Something got infected somewhere along the way. These patients, though, post-operatively, are sent home relatively quick. I know I used to give home health. They had the surgery that day. I see them the next. Sometimes we'll keep them overnight and then send them home the following day, depending on which type of procedure they have. If it's a lumpectomy, they might not see me. But if it's a mastectomy in any form in home health, I saw them. Usually home health is supposed to see a patient with a mastectomy within 24 hours of discharge. To make sure they're keeping, because you will teach the patient at home how to take care of these drains, because they do go home with them, how to record the fluid output, how to monitor their own site, and that's actually what home health is usually for too, because we keep a pretty good eye on that incision. The dressing change is always going to be dry. Some doctors do open to air. It depends on your doctor in there. But you're going to educate your patient all about this and what to expect. And I'm afraid some of these scars are pretty ugly looking. Although I have seen like the coolest tattoos that they do over the scars that are really like nice. I need to include one of the pictures of those just for the heck of it. This is reconstructive surgery that they can do during the mastectomy, after the mastectomy. Some doctors like to let everything settle down first because things tighten up and they draw up. So they'll wait to do this for like 6 months. They'll make sure the patient's stable before they send them under the knife again. But what they use, and you see this, they'll take a tissue flap from the abdomen and they'll take your belly button. Because they can use that to kind of form the nipple area. So you're not totally lacking there.
There's a doctor in New Orleans that will take fast and build your boots and then we'll tap you.
There are actually now some tattoo artists that offer to tattoo a nipple that matches the other one. So if you have a unilateral mastectomy and you want it to look like the other breast, they'll tattoo something that looks similar to the other. If you have bilateral, they'll just come up with something that looks like a chat for. Okay, in this situation, she had a unilateral because she's covering up the other breast. Alright, post-operative care on these guys too. Remember I was talking about the lymphedema? You don't do blood pressures, needle sticks. Don't put restrictive anything on that arm because it can cause it to swell up. They're going to have their arm, usually we want them to prop it up on a pillow when they're resting, and they need to prop it up several times during the day. When they first start getting up, they may have to, have it in a sling or something, but we want them to work to where they can actually hang their arm down by their side. They'll have to work to that. I already talked about the JP drains, because I always get ahead of myself. The incision, clean, dry, some of them are stapled, some of them are glued shut. It really depends on your doctor there. The head of the bed should always be elevated at 30 degrees or greater. Elevate the affected arm. When in bed, once you can get them, when they're walking, to drop it to their side, leave it that way. Let them get used to it. Pain management. What type of pain management are these patients going to be getting?
Like morphine.
Morphine. And there's a nice happy little letter word called PCA. It's patient controlled anesthesia. These people come with it. They don't go home with them. But if their pain is unmanageable, they have these so that if they wake up and they hurt, they can take it. Usually they're given it pretty liberally for the first 24 hours. After that, they start knocking them down a little bit. Because 24 hours after surgery, they want you up and walking around. Because what are the big risk factors of any surgery? I know, it's on my PowerPoint, so you already know. DVT, they can get pneumonia. We have a lot of issues from just plain old surgery. And then we're working on all these drugs that they're getting, stopping estrogen, so they can always cause a DVT. Especially if they're being a whole lot more sedentary. If you're normally an active person and you in for surgery, there's a chance you could develop a DVT just because you're not as active as you were before. Why our main DVT prevention is ambulation and Lebanon. Y'all will get that later. I'm not lecturing on Lebanon, but it's just blood thinner. And a lot of times they'll give you a subcutaneous shot in your belly. Their exercises, they start the next day. They're going to do simple exercises that don't really pull the incision initially, and the doctor will write, so you don't have to worry about that, what type of exercises he wants. The normal ones are things like flexion and extension of the elbow. A lot of times we tell them to do finger combing through their hair. And my favorite one where you learn to walk up to the wall to start stretching those muscles again. It's a finger walk. That one, believe it or not, is really hard the first few days after surgery. I've seen people that can't even get to this point on the wall because all of that's starting to tighten up and they're still really, really sore post-surgery. We've already talked about reconstruction, so I'm not really going to go back in there. Do know, though, that it is an option for your patients. Make sure to let them know. And usually they use, just like they would for breast implants, they'll have silicone or saline implants in there to give them the nice look and feel. Okay, they don't need to be stressed out, so when they go home, we want them to sleep when they can. Don't get overly fatigued. They're still going to elevate that arm when they're in bed. Remember, only when they're in bed. No heavy lifting, nothing over 5 pounds. No, let's see. No straining. I'm just going to make sure the child knows. Make sure they know to tell people to avoid those blood pressure and just needle stick. Tell them that arm is off limits for the rest of their life, unless absolutely necessary. And to stick a mastectomy patient on the affected arm, you actually have to have a specific doctor order that okays you sticking that arm. Same thing with dialysis. Although preferably with dialysis, you'll just get a central line. Their exercises are per the doctor, but they're going to start them off easy and then work them up. They'll have physical therapy to do exercises with.
What if they had a bilateral mastectomy? You don't use either arm?
Actually, that really depends on what the doctor did as far as mastectomy. Some of them are they're you're screwed either way, so they'll either say that you can use the lower arm, or the doctor will have to write an order to get a venous puncture in the leg. Usually we'll do blood pressure in the leg. Y'all know how to do a popliteal blood pressure. The difference is you get one of those thigh blood pressure cuffs, you put it around the thigh and you find the popliteal artery, and you listen there. It's a little harder, and the patient has to move their legs a bit more, but it is possible. Now, I will say that usually if they've had a mastectomy and it's been bilateral mastectomy, it's been 20 years or something, as long as they're not having a lot of lymphedema, the doctor will okay getting needle sticks on the arm. My friend, she had a bilateral. I think that they okayed venipunctures for her, but she can't have IVs in her arm, so they just put in like a femoral line if she ever needs anything. And she has what's called a nice little infusion port. She had that for the first couple of years. And the infusion port, y'all know, is a line under the skin. It's like a little circular device, and it attaches to your arteries, your veins, and it hooks up in there. And it's under the skin, doesn't have to replace or anything unless it gets infected. And they're good for several years. And all you have to do to access it is take a needle in. There you go. Yeah, no, I think I learned how to actually do access for that in level 4. If not, if we have clinical and y'all get the opportunity to put one in, I'll help you do it. Alright, these pictures are not great, but these are exercises. There's our wall climbing exercises. That one's more advanced because you see how they're going up. And usually out in the first few days, you're lucky to get up. So you don't get that whole double arm thing. And even that one, they'll start with like a pulley. And they'll start here and advance to there. I cheated. Now I just tossed this in here for head. The nurse understands that the estimated number of deaths in males each year attributed to breast cancer in the United States is what? 1%. Right, 1%. But what do you think the number is? No, it depends on how many. And the average is usually about, I want to say, 22,500 women every year. So your men are 1% of that. So that was good. Let me break this thing real quick. It is 225. All right. A premenopausal woman reports a palpable mass on her right breast. She also has a greenish-brown discharge from the nipple, redness and swelling over the mass, palpable axillary lymph nodes, and the nurse suspects that the patient's condition is It is benign, but it's actually infectious. Because remember that, ductal ectasia? Where I talked about the greenish nipple discharge, it's infectious. Alright, the nurse understands that which age group of women has the greatest chance of being diagnosed with breast cancer? Well, I said young women don't get diagnosed very often. Believe it or not, it's 60. The older you are, the higher your chance. That's why I snuck these in here, because this way I make sure y'all get extra information here.
Longest exposure.
Because the older you are, the higher your chances of getting breast cancer. If you've had this breast for a while, there's just things going on. Alright, there is a case study. It's up to y'all if y'all want to do it. If not, why don't we take a break and then we'll get up to the vaginal stuff. I'm going to give y'all about 10 minutes. Okay.
What do we want?
Yeah, be back here at 11:10. You got 45 minutes, okay?
I will not make it 45 more.
Oh, go hit up the vending machine.
That's chaser.
Actually, no, because you got something decent in that.
Those are expired. Have you ever got one of these?
Yeah, I did.
The last
threw
one I got
it
one
away.
was expired. It must have been $7 for an expired salad.
I hit up Subway for that reason, because at least then you know if you're paying $8 to $10, you know your food is good.
Hopefully. We just don't get to see the expiration date on it.
True. So y'all like the content so far?
It really hurts.
Like I said, most people want to go see the doctor. Hey, even I do after this thing. I'm like, I just saw the doctor in November, and I'm like, Get another appointment like you had.
Nope, I had one in Virginia when I lived up there, cause I have like, lumps like that, and it's just the cyst stuff.
Yeah, the
Like,
fiber
I'd rather
cystic
have them
breast
all
disease.
removed than on this side.
And this is the other part, so I was gonna warn you. Except for like the first 2 to 3 items. Do you think my photos were bad earlier? It just goes downhill from here.
So how old was your friend when she was diagnosed with this?
She's 30. I don't know how old her younger sisters were, but I do know they all ended up having yeah, that's why you remember Anthony Jolie like 5 or 10 years ago. Just get rid of the rest. If they're gone, they're gone. You don't have to, you can't have breast cancer. Where we talk about that survival rate, if it doesn't metastasize, we usually say 36 or metastasize. Or they I have a aunt who was 80 and she had breast cancer. She did all the treatment for that. She did good for like 2 years.
About being able to give the answers. About questions, how do I fix it?
How do I go back and answer them for you?
I didn't know y'all couldn't see it at all.
Yeah, it just shows that we submitted it and that's it.
Well, I was hoping I had it before y'all went, but we'll just call it done.
Okay,
But in the future, you never see
You best back off, you know, bite your finger.
okay,
it. Never.
Gotcha.
And it needs to, because you're learning.
right.
There's time frame to it, and RNs need input, and not only that, so you need that professional.
Okay. But I do have the other.
Miss Husley, I need y'all out 15 minutes early, because level 4 is coming.
Okay, so 11:45?
Yeah, I know that tear everybody up.
No, that just means that Friday's gonna have more content.
Yeah. So thank you for that, and
I already fussed at them about the floors.
about the what?
The floors.
The floors.
Cleaning up around our area, picking up behind ourselves
Yeah.
and things.
Yeah, let me.
I submitted my med cards. They was on the same thing, like them 3 pages of the care plan. I couldn't separate. So the med cards are with my
Did I give
care
you
plan.
send you a copy?
That's why I was telling you.
Hey, look, go back and,
I'll look back at it.
Yes, ma'am.
I say, or you could have submitted them both in both places.
That's what I did.
Oh,
I did like I had because I couldn't submit it, so I had the care plan and the med card.
I couldn't at first and I had to go back and rescan.
Y'all was
He's already did mine.
Wait, do we have to do any of that before we go?
Yes, sign into it, just gonna ask you for your new password.
Like the same thing that I signed in, like at the hospital?
Your own tax return, sorry, email. Because I tried to use my one from the hospital and it wasn't working. On Track is what we signed into ourselves and did the pre-stuff, remember? And you gotta send Miss Husley a new certification letter, or the certification letter.
So you're gonna
Since
have
we already did it, there wasn't anything for us to do any further. So I just sent her the one I had. Did you get that? Did you look?
I couldn't find it in there.
I just now sent it again when I asked you.
Okay.
So it should be there. But what I was telling her is when I signed into my own track, because she's been there with me at clinicals, it didn't have any extra new stuff for us to update. It just wanted us to update our password. Like it didn't have any new training or anything like that for us to do in the own track. Since we've been there 3 semesters already.
Yeah. I think only 4 students.
So I just sent you the certification that we got last semester.
Perfect.
But yeah, OnTrack is gonna make you put a new password
If I
in.
don't get it, I'll email you.
The capital letter down? I have to do the capital letter? I'm just trying to remember my stuff.
Yeah, I think so. I think so. Yeah, it's the one at the school, I mean, at the
it's like my
hospital in
personal
Epic
email?
that we have to have that extra symbol behind it. Okay, gotcha.
I'm waiting for you.
Guys, I'm going to set an alarm on my phone. The only thing I cannot guarantee is what it will sound like, so that we know to kick out of here. I'm also going to kick out some of the A&P stuff. That's nice to know, but not necessary to have. We got an extra minute. Y'all got any ideas for excretions that sound like fun?
Excretions.
That's all excretion is kidney problems.
Nurse area doesn't like that stuff. You ever seen nurse area? That's part of excretions also.
I'll go look it up. In fact, next semester for level 2, I'm going to kidney my head.
Stones, basically.
You
We used to say it.
Yeah.
I like to have like no activity. The only one I really don't have activities. I just have like a photo stories.
One thing, if you are taking the dosage count test at 1 o'clock, just go upstairs to the upstairs lobby and we will come get you for that test. If it's set for 1, so if you're just up there, I will come get you all and put you in the back in the room to test. So I will see y'all in the lobby and have everything you
On their own computers or school?
I'll have school computers. I will have everything, calculators, computers up there and ready to go. That's it. We'll leave you. Oh. Oh, you did?
All right, guys. Now that we have the upper portion of the female body covered, we are now going to discuss the lower portion. I'll give y'all a short A&P. Y'all know about the vagina, the uterus, the cervix, the fallopian tubes, and ovaries, right?
Yep.
Okay. These are just actual pictures of it. Your cervix, and this is just an internal view. Uterus, ovary, fallopian tube. It looks like it's a laparoscopic exam. Yeah. But I'm going to skip forward to endometriosis.
Not fun.
I know. I told you all of this stuff is not fun. You want to go to your gynecologist. All right. How many of y'all know what endometriosis is? All right, want to share? Yeah. It is basically the growth of uterine tissue that goes outside of the uterus. It's like an excessive overgrowth. They're not sure why it happens. They just know that it does.
Was she in the bathroom?
All right. I know there are a lot of these disc things, but these are the signs and symptoms. If you've ever had endometriosis, y'all know what these words are? Dyspareunia. That one took me forever to learn the pronunciation of, because it sucks anyway. Dyspareunia is actually painful sex. Dysmenorrhea irregular, weird, funky periods. They're either too heavy, they're too light, they come every 22 days instead of every 28. Pain with bowel movements is dysphagia. I had to remember that one myself. And infertility. Believe it or not, women with endometriosis, they tend to have a lot of abdominal pain. They have a lot more cramping than normal. They also run the risk of, after the age of like 30, being infertile. So sometimes, and I know this is scary, if we know an 18-year-old has endometriosis, we'll recommend if she wants to have kids.
Go ahead and have them.
For 25. We'll recommend to have babies early so that she doesn't run that risk of having infertility.
I just sent them
I had
that
a
way
friend
too.
that was home at 16.
Mm-hmm.
She got pregnant at 17 in school, and then a full hysterectomy.
Yeah, see? I actually knew this little boy, he was 19 years old. And he was so excited because, see, his girlfriend had endometriosis and it was so freaking bad that they told her she was already infertile. And she was 19. And then all of a sudden they found out, whoop, she's pregnant. And he was so excited, even at 19, to be having a baby because he knew that it wasn't supposed to happen for her. He was a bit young and had a lot of lectures on how to handle babies. But they were so glad for that little girl because they knew she wasn't supposed to be there. All right, benign neoplasms. These are ovarian cysts. If you've ever had a cyst on your ovaries, it sucks. And when they rupture, it's even worse. Some people can have bleeding into the abdomen from them. They're also called, and then you have uterine leiomyomas. They're also called myomas or fibroids. This is where some of my stories start coming in. If y'all don't know me very well, and I know y'all don't, I have a hippie mother. My mom, and she's not the whole flower child, smoking whatever kind of mom. She's the natural herbalist, never touched a vaccine in her life. In fact, when she got her new job working at a pathology clinic and they made her get some of her vaccinations to be there, she called me to know exactly which ones she had to have and which ones they were just full, because she had said they were BSing her on them. So we had to go through every one. Because I had to tell her that flu was optional, she doesn't have to have that one. But the reason I tell you about my mother is because she had uterine fibroids when I was in my 20s. And the treatment of uterine fibroids or leiomas depends on the size, the issues that they're having with them, and the type of management is going to be based off of that. I also have a friend who is my age who had these, and now they put on birth control to help balance them, and they told her though, because of her uterine fibroids, she already had 2 kids by the way, they told her that she wasn't going to be able to have any more because the fibroids were large enough they would interfere with fertility. So she went on birth control for about 2 or 3 years to help with the size, because if you decrease the estrogen, usually uterine fibroids are pretty on that. Well, she did this, and after about 3 or 4 years, she decided, well, since they already told me not really got a chance to get infertile, I'm not going to worry about this. And her son is now 6 years old. So y'all, just a heads up, don't believe everything they actually say about infertility. They can declare you infertile, and boom, you have a baby 6 years later. Or like my friend, she had a baby 9 months after she stopped the breast control. What?
So did the birth control shrink the fibroids?
It did. They said what happened is that since she was on that birth control and it helped regulate and decrease all that extra estrogen that's causing the fibroid tumors to grow, that because fibroid tumors are like an excess growth of like the muscular tissue in the uterus. So when she took that, it balanced out the growth, and it actually shrunk drastically. She just decided not to take her birth control anymore, so she had space in there now for an egg to stop by and get implanted.
So was she
management.
thrilled? I said, was she thrilled?
Actually, she was. Her little boy is the light of her life. He is a handful, and he's the only. He's one of her only boys that really is like this outgoing, absolute personality. He loves you. He loves everybody. He's going to talk and make friends with everybody else. And her other two sons are more introverted, like her. So he's just like this whole polar opposite. So she just thought it was the greatest thing.
Because ovarian cyst, that's where you get PCOS from.
You can.
Because one of my friends, former soldier line, she had PCOS, so she would never have children. And I think she's 28, and she's now pregnant with her second in 3 years.
Well, that's why I said don't always believe in fertility when they tell you, especially since things change over time.
And then there's another one I saw where the woman had fibroids. Originally, all she had complaint was anemia and being low in iron. Didn't know why. Then I think she waited 8 months, and it was just she noticed her abdomen started, went to get seen, and it was a fibroid the size of a 20-week fetus.
Well, let me get to that. It also depends. Your treatment and your management really depend on the size of the fibroids themselves and the age of your patient. Because the younger ones that want to have babies, they're going to try to do what they can and maybe do like a surgical excision of the fibroids, cut them out, get rid of them. They will also treat. The other treatment is removal, hysterectomy. For uterine fibroids, it's not always. With my mom, that was her solution. Because, like he was saying, my mom's fibroid was actually the size of a 5-month pregnant woman. Yeah, it was huge. But here's the thing about uterine fibroids, and I'll tell you something. They have bleeding. It's bleeding in between the menstrual cycle. And it's usually every 40 days. My mom called me because she knows I'm in the medical field. And she said, honey, I'm bleeding every 2 weeks. It's like I'm on my period all the time. I said, well, how bad is it? Not bad. Never take not bad from the hippie mama. Because not bad means she's not dying and doesn't need to go to the hospital. It took 3 different conversations over 3 months to find out her bleeding was bleeding through a maxi pad, a tampon, and clothes.
Yep.
She would bleed so bad that she had to change her clothes at least twice a day.
Yep.
While at work.
She got a hysterectomy too, didn't she?
She sure did.
So did I.
She was so anemic by the time she went to see the doctor that they wanted to give her a blood transfusion. Of course, my mom didn't want my blood transfusion. She took like 15 iron pills a day. And if anybody's ever taken iron pills, she did the stuff that was in the capsule. And I'm glad she just swallowed it because if you ever taste them outside of the capsule, it tastes like you're eating your own filling.
What, the iron pill? Mm-hmm. Oh yeah, they're disgusting.
The capsules, they taste like you're eating your filling. It's a nasty idea. But you look for those signs and symptoms, and they have the swollen abdomen, because my mom lost 20 pounds when they took her uterus out because it was so large. They have some tenderness, that excessive bleeding, and y'all make sure to get a pad count. Because if you're saturating a pad, a tampon in your clothes in 2 to 3 hours, you really have a problem. You shouldn't be bleeding that bad, even during a regular period. Because uterine fibroids do affect fertility. My mom was in her 40s, so thank God. Because I'm just like, Mom, you just need to get it cut out. Don't worry about it. And I'm like, you're not having any more kids, let's be honest. She finally did listen to me about that one. The treatment, because of our family late history of menopause, expecting her to go through it in her 40s was like, no. But with menopause and the decrease in estrogen, yes.
Okay. Are these disorders for the assessment? I'm trying to follow along with the
It's for the physical therapy?
Yeah, you have to know about these. These are for the physical stuff. Y'all have to know what to look for when they have issues like this. Large ones, like my mom's, hysterectomy, excision, if they still want to get pregnant, they'll use that Lupron. Lupron was mentioned for during my BPH lecture. What it is it stimulates the overproduction and then causes the shutdown production of estrogen. The luteinizing hormone. In women, it stops estrogen and then it stops FYI. Now, unfortunately, then we start getting into malignant disorders. That's where all the cancer comes from. And I promise you I'd rather talk about my hippie mama than cancer sometimes. But usually you have cervical, uterine, vaginal, ovarian, and vulvar cancer. A lot of the early symptoms are vaginal bleeding. Sudden vaginal bleeding after menopause. Sometimes the symptoms depend on the location. Remember, ovaries up here, they might be hurting. Uterus here. All right. Treatment and procedures, biopsy, excision, radiation, chemotherapy. They're also, some of these treatments can be curative and sometimes they're palliative. If they're hurting really bad because of a tumor on their ovaries, but we already know it's from the breast, they've got breast cancer, like that picture we saw earlier, that really bad breast cancer, they may just remove the ovary to help them feel better, but it's not going to fix the cancer, it's already everywhere else. They can do that for therapy, for palliative treatment. They'll also sometimes do palliative radiation therapy, especially if metastasize to the bone, to keep them walking and moving on. Alright, so what type of post-surgical care would somebody who's had a malignancy surgery? So, let's see, an excision, removal of the uterus.
No sex for a certain amount of time.
Yeah. Pillow splinting, that's a good one. And keeping the incision clean and dry.
Post-surgical chemo.
Post-surgical chemo, what to expect about chemotherapy, what differences, what changes, will they lose their hair? Slightly. And you're also going to do just like you normally would, dressings clean and dry, make sure they know how to change them, monitor for bleeding, monitor for any abnormal looks, because if they didn't catch all the cancer, it could still grow out of the area they were in. Since estrogen tends to be a factor in uterine cancer, they will sometimes just take out the ovaries as well as the uterus to prevent the production of estrogen. Usually uterine cancer is slow growing, so it's a little harder to find. The lady I was talking about earlier who found something that felt like a stool can, it had been 5 years since that person had had a pap. So there's a good chance that uterine cancer had been growing the entire time she hadn't been to the doctor. And it usually starts out, just something minor, but you don't notice it because it's slow. That's one of the reasons we get these pap smears and they do that check. Women know what I'm talking about. Men are like, nah, you don't want to know.
Can't you still get some of those cancers even after you've had a hysterectomy?
If you've had a hysterectomy,
Like if they leave an ovary or something.
if they leave an ovary, you can get ovarian, but you can't get uterus because your uterus went out the window. The same with the cervix. A lot of times they'll go ahead and take out the cervix with the uterus. I know for my mom they did, so she doesn't even have to worry about cervical cancer. She does
So why do
have
they still make you have a pap?
to monitor you for things like vulvovaginal cancer, HPV, especially if you've had HPV exposure. Y'all know that if you HPV, genital warts, HIV, STDs can increase your risk of getting these types of cancers, especially if not getting treated. Yeah, that's the reason we talk about all this.
So they could take out the ovaries, uterine, and cervical, and it would prevent all those cancers. My mom had a hysterectomy, she had all those taken out.
Yeah, my mom, the hippie mama, she left her ovaries because she just didn't want to go into menopause. She still has menopausal-like symptoms, but they're not as bad.
Yeah, the doctors want you to keep them if you're young. I was only
Oh, maybe
31.
she kept her ovaries.
Now, with
I was only
uterine,
31.
with uterine cancer, white females are more likely to get diagnosed with it, but African American females are more likely to die of it because they don't go to the doctor as often, don't get it checked out as often. One of those you push it aside. I don't need to worry about that right now. Heck, I think nurses need to be on that list too. It's not going in as often as it should.
Well, yeah, because they don't even get to go to the bathroom or take a break. I said, yeah, because nurses don't even get to go to the bathroom or take a break.
Right.
So they don't even get a chance to go to the doctor at
So
all.
they're not worrying about it.
They need to pee on their time when they're not at work.
Actually, a lot of nurses I know, when they work in a facility, they'll tell you that they tend to rehydrate on the days they're not working because they really don't drink during that 12-hour shift, and then they get home and they drink what they can, and then when they get back to work the next day, they're not drinking all day, and then on their 2 days off, they're like, I drink like a fish, because it compensates for them. This is where things like hormone replacement therapy, with uterine cancer, this is where your increased risk is. Hormone replacement therapy, birth control pills. I know. Somebody just went, oh, I'm not sure I want to take that stuff anymore.
Take it all out.
They won't let you.
The good part though
I'm not gonna bleed to
is,
death like I was.
if you have a baby, pregnancy decreases the risk of having uterine cancer. And they didn't put an age limit like they did on breast cancer. So if you had a baby, your chances of having uterine cancer are
Babies
less.
are so expensive.
Aren't they? Mine's have cost me a fortune already, and they haven't even made teenagers.
Well, from birth to graduation, they cost you $1 million.
All right,
I didn't even know I had $1 million. How'd I lose it?
because you paid for stuff for
I
them.
know, right?
Okay. Now, what are the other increased risk factors? We already talked about them for like breast cancer. What would they be? Smoking, family history, obesity, that poor, crappy diet we've been talking about. You know, all those ho-hos and cupcakes and stuff.
Ding
Real
dong.
high fatty diet. I'm not going to
Ding dong. Swiss rolls.
Yeah, high cholesterol.
Girl Scout cookies.
Oh, Lord. Don't talk to me. My dealer already gave me my stash.
Yep, I got mine too.
Okay.
Shay, you ready for some more yet?
She's already got them.
All right. Also, women with diabetes are more likely to develop uterine cancer. Okay. Adenocarcinoma is the most common type of uterine cancer. By the way, I added endometrial, so you know what I was talking about, just extra. The most common sign is postmenopausal blinking. If your patient says, well, I went through menopause about 5 years ago.
All of a sudden, I'm bleeding.
Yeah, I just started my period all over again. You'll be like, God, no, we need to check you out. Their diagnosis is usually going to be, they can do a biopsy, where they go up in there and put a tube up through the cervix and get, it's like a 5-needle aspiration. They pull out some of the tissue from the uterus. They can do MRIs, CTs, the PET scan we're all familiar with. I'm gonna make sure, because one of these has a gold standard. I want to make sure y'all get. Oh yeah, the CA 125 tumor marker and alpha fetoprotein.
CA.
I know it was this one. Transvaginal ultrasound and endometrial biopsy are the gold standard for diagnosing this. I put this in. If it's not in your books, it came from mine. I used some of my nurse practitioner stuff to add the right information.
Can you repeat that?
The transvaginal ultrasound and endometrial biopsy are the gold standard for diagnosis. And a lot of these things really just determine on how advanced this uterine cancer is when we found it. Depends on our course of action and how healthy your patient is. Because if you get a 35-year-old woman who has this, which we hope not, but 35-year-old woman who has this, except she just has extra bleeding in between her periods, thought it was fibroids, and it's not. Her chances of getting better and going through all the treatment is a lot better than some 85-year-old who just developed postmenopausal bleeding, who has a history of CHF, COPD, diabetes. Your options kind of go down with all those you're listing in there because you've got so many comorbidities, and since uterine cancer is so slow growing, the chances of cancer after killing are probably slim to none. Prevention. Annual exams. Watch for symptoms, which there sometimes aren't any, so it's kind of harder to keep in mind. Treatment, total or radical hysterectomy. Y'all know the difference, right? Total hysterectomy, they're usually just taking out the uterus. The radical tends to take out the uterus, the ovary, the fallopian tubes, the whole 9 yards. They also get this running on this. Yeah, here. Bilateral sapling nephrectomy and nose implant. That is taking the ovaries and the fallopian. The sapling is the fallopian. Nephrectomy is ovaries. And yes, it took me years to learn how to pronounce that properly. All right, your surgeries for your hysterectomy can be laparoscopic. I'm not always a fan of them if you have uterine cancer of it being laparoscopic because they usually cut it up inside you and yank it out. And I'm not exactly a fan of them going in there and cutting up something that might have cancer cells. Usually they do the laparoscopic if it's something else, like certain fibroid tumors. They can go ahead and cut that up and yank it out. There's no problem there. It's kind of like how they get rid of your gallbladder. The thing about it is they also can go through the vaginal, through the cervix, pull the uterus out, take out the cervix too, flip it all off, sew it up. With the that one is a good one unless you're like my mom. Remember I told y'all she had like one like a 5-month pregnant woman. They had to do an abdominal because they couldn't pull that out that way. So they had to do an incision, almost like a C-section, up underneath, pull everything up and pull out the uterus. She was not happy about that. She's mad at me because it didn't point out that was probably where they were going to go. Also, with the radical hysterectomy, I did forget to mention this. The radical, sometimes they'll take the top 2/3 of the vagina. Yeah. If they think the cancer might have spread that far or they're running the risk of removing it, they'll take it.
So then it just
I'm not even going to
shut
lie.
up.
They will take what they need, and if they interfere with some other things, well, we'll just have to worry about that later.
My mom went to gutter.
She wants to let her in. Got it. Miss Lyman's coming in. Yeah, but I'm sorry.
on, you can take them. I know, I'm just gonna sit and wait. I just couldn't, if I wait too long, y'all release them, and then I'm like, they're gone. So I'm
She
like,
escaped from the mental ward again.
huh?
She escaped from the mental ward again.
And then yellow.
We don't know. What I'm hearing the voices, they're telling me the lecture time.
There's people you can talk to about that.
All right, we've already talked about how this is
Did they
supposed
tell
to
you
be.
about the cliff? Are you going to the bridge still? Where's your hand sanitizer? Where's your Coke? I don't see no Coke.
Oh, that's up at my desk. All right, guys, we've already talked about how the types that will be performed, so I'm not going to go back into that. The indications, abnormal uterine bleeding, fibroids, cancer. The psychosocial assessment on these patients. Remember how we were talking about having the mastectomy and how they'd handle that? How do you think they're going to handle a hysterectomy?
About the same. We're not a woman anymore.
That's
so I
right, they don't have a
anything.
uterus. Oh, my mom, remember I told y'all she's hippie mama.
No, I don't have
she
none
did
of that. I
not
got a
handle
playpen
that well
now.
because, first of all, even though she wasn't going to have babies anymore, it meant no more children ever.
I was excited.
It meant she didn't have a uterus, so she wasn't entirely a woman anymore because that's something a woman has. And what about these women that have to have the radical where they take part of the vagina as well?
Now that one I don't know about all that.
Body image issues. They're going to have issues about sexual performance. They're going to have issues as to whether does their significant other now view them as terrible because they're malformed down there now. Things aren't right the way they're supposed to be. But then again, after you have surgery down there, it's 6 to 8 weeks for release from your doctor before you can have surgery.
Yep.
Post-operative care, what's the biggest risk for these people that have had hysterectomies?
Oh, no picking up any heavy stuff.
Right? Excessive vaginal bleeding.
For hemorrhaging.
They might start hemorrhaging down there. My mama, who likes to be smart, remember I told you she's a big mama, she does what she wants. She decided that she was going to take herself to the bathroom and not take her little pillow and not ask anybody to help. Even though my dad took off work and stayed with her like 24/7 because she had the abdominal, she was in the hospital for like 4 days. And the reason she was in the hospital for 4 days is because on the second day she decided to go to the bathroom by herself. You know what happened, don't you?
She fell.
She didn't fall, she twisted wrong and ripped open that incision about that far.
Ouch.
Yes. She did not have, thankfully, her bowels or nothing decided to pop out because I think I'd have had a heart attack if she did. Although that is a possibility, so FYI.
That snakes.
And remember that sterile saline gauze over the area. Make sure to keep it damp if they do actually have their bowels poking out through there.
Oh, God.
For her, it ended up meaning going in there, and the doctor had to go in there, clean it out, and daughter had to come by and clean and pack dressing because mom didn't want to listen to the doctor. So y'all remember to make sure to tell them to the first few days get up with assistance. Be careful about bending or twisting the wrong way. To watch for like those peri pads, they should only have like one. They're still going to have some vaginal bleeding. You're going to expect some, but if they saturate more than one pad every 6 hours, every 4 to 6 hours, then you're going to start noticing there's a problem. Because if they're saturating a peri pad like every 2 hours, it's usually a sign there's some more bleeding going on. History. Do they have a family history of cancer? So this is going to be your assessment. How are they prepared to have that hysterectomy?
Yep,
You're going to want to know their drinking, smoking,
none of the above.
because I promise you, you don't want somebody who's been used to having a glass of wine every night to suddenly start going through DTs. And I promise you, I had a doctor prescribe. What
Beer?
did she have? She had a glass of sherry, and the doctor read an order for a glass of sherry every evening, so we didn't have to worry about DTs. They're going to have a physical and a pelvic exam. You're going to do your assessment. You're going to focus on the pelvis, check for any masses that you can feel upon assessment. Afterwards, you're going to be checking for that vaginal bleeding. You're going to check the incision site. Like my mom, you had to check for like that C-section incision site. Psychosocial and emotional response. They're having a lot of anxiety in the beginning. They're having a lot of pain. They don't feel good. Everything's changed now. So this is why you want to make sure you educate them before they actually go to the surgery so they know what to expect afterwards. Because telling them what they're supposed to do, like that no heavy lifting, even though my mom got it before surgery and everything, and she knew better than to get up when she did. You have to make sure your patients are educated before surgery because afterwards they're not going to fall over. They're going to be hurting too bad, they're going to be uncomfortable. What you said, out the window. So if you tell them to stay in that bed and don't get up and you're not reinforcing what you told them 24 hours ago or 6 hours ago pre-surgery, they're not going to listen to you. They hurt. They need to get up. They think they've got to go pee. They usually have a fully catheter for the first 24 hours, so they may still feel that urge to go pee. They're going to get up and try to do it. You haven't warned them about it.
And they'll go with their family, and their family thinks they can help them, and then they both will go on top of each other.
They'll try to go with their family.
Especially people my age group, we're the worst.
Especially if they're nurses.
Yes.
Alright, I am looking at my time and I now have like 1 minute left, so we're going to finish this up on Friday. I'm going to let you get what you need.
Yeah, so we